Hello and welcome to the Spine and Nerve Podcast. My name is Dr. Brian Joves.
And my name is Dr. Nicolas Karvelas.
And thanks for joining us today, everybody. We are going to continue our discussion on discogenic pain and actually present a recent article that I found pretty interesting, and I shared with Dr. Karvelas, and we'll get his thoughts on it relatively soon. But looking at different ways that we can address discogenic pain. And maybe before we jump into this, and the article specifically is going to be looking at some of the orthobiologic ways of treating discogenic pain. But just to kind of give a little bit of background, I know from our last episode, we didn't get too much into the details about how we tend to treat discogenic pain. And obviously we've always start with the basics, and we always talk about all of the other modifications that we can make for people. Weight optimization, health optimization, exercises, using external tools to be able to help, such as TENS units and back braces when appropriate, medications at times, and then we get to some of the interventional options. And so I think that's where it gets a little bit tough, because discogenic pain tends to be a little bit different than some of the pains that we've already talked about, right? When we're talking about purely a lumbar radiculopathy or lumbar stenosis, or even the facetogenic pain, I think we have much better tools to be able to specifically target that type of pain. And so as we're thinking about discogenic pain, obviously there are a lot of tools, and I think there's a lot of things that we do, and especially with experience, that can be helpful for patients, but I would say it probably tends to be a little bit less predictable in terms of response. You think that's a fair way of saying it?
Yeah, to your point, when we think about the different levels or gradations of evidence for the image-guided therapeutic options we have for these different pathologies, to Dr. Joves' point, when you think about facetogenic pain or radiculopathy, that whether it's a systematic review, meta-analysis that's been done evaluating it, and I think we've discussed these in the past, although there are some positive results for treating discogenic pain, if you look at those levels of evidence or grades of evidence, they're going to be higher for that facet or radiculopathy, which I think to some degree contributes to this push to find a safe and effective treatment for discogenic pain from an interventional standpoint.
Yeah. And so, we have things like epidural steroid injections, like you brought up. Historically, people have done intradiscal procedures. We briefed a little bit last episode on discograms, and discograms, technically speaking, are mostly a diagnostic procedure, but there's definitely some evidence, for putting steroid into the discs and being able to have some ability to treat the discogenic pain with steroid into discs. And so I think that all of those are options, but like you said, when we start looking at, large meta-analysis and, or, randomized controlled trials or the lack thereof, the evidence sometimes becomes a little bit spottier than for other things that we have. And so we continue to look for better and better options to be able to help with discogenic pain. And one of the things that's been coming up in the literature, I'd say probably over the last 8 years or so, has been a lot of the orthobiologic options. And so you want to give us a little introduction to this article, and then we can kind of go through some of what they found and try to see if we can add more things to our lexicon.
Sounds good. And so the article specifically is titled Interventional, Intervertebral Disc Degeneration, the Role and Evidence for Non-Stem Cell-Based Regenerative Therapies. This was published by Dr. Singh and colleagues, published recently in April of 2021. So in terms of the article itself, obviously one of the major things it highlights in the beginning is the thought process behind why there's such a push for these therapies. As many articles do when they're addressing treatment options, they show the burden of disease, right? And we covered this, I think, fairly extensively in prior talks, including our basic science talk about disc degeneration. But just quickly to highlight a couple of things. So, as we brought up in terms of the definition of discogenic pain or pain due to disc degeneration, as we know, as we discussed, this is a painful disease process due to compromise of the disc which is often characterized by factors including but not limited to degeneration of that disc, loss of the disc height, loss of hydration of that disc, the development of certain factors including annular fissures and modic changes, and ultimately presenting in that patient typically as centralized debilitating low back pain. And when we talked about previously the global burden of discogenic pain, we know that this, both on an individual as well as a societal and global level, this has huge repercussions. I remember reading, I think in this article, $250 billion annually in the United States when you think about both loss of productivity as well as costs. And then when we think about a patient presenting to our clinic with low back pain, studies would suggest about 40% of the time discogenic pain is playing a prominent role in that chief complaint. And so, as I said, bottom line, this is a common disease process. It has huge repercussions both on the individual and societal level. And as Dr. Joves brought up, we're still working on that optimal treatment option, especially from an interventional standpoint. So now, one of the things that this article really highlighted was that an understanding that it's helpful to have an understanding of the underlying basic science and pathophysiology of what's going on with disc degeneration, because that ultimately leads to the mechanism of action behind these different therapies, especially when we think about platelet-rich plasma and utilizing growth factors to try to have a positive impact on that disc. It makes sense when we think about what's really going on with that disc. So I just wanted to highlight a few of the things that was brought up in this article, because I thought they were good points. And we did discuss this to some degree in our previous talk when we were talking about the degenerative cascade of the spine and the changes that happen with the disc, including the changes in the collagen type, whether that be predominantly type 1 in the annulus fibrosis or type 2 in the nucleus pulposus, and the transformations that happen over time, or the loss of the proteoglycans and the loss of the disc hydration. So we've discussed that, but one of the things that was highlighted in this article was that there's this imbalance between anabolic and catabolic processes in the disc. And with these increase in catabolic processes, one of the things that tends to drive those catabolic processes includes increases in certain proteinases, including the matrix metalloproteinases, and growth factors will play a prominent role in which direction that goes. And when we think about on the other side, the anabolic processes, again, growth factors are playing a prominent role in that as well. And I did want to go over a couple of those because they come up when we think about what growth factors are involved in platelet-rich plasma and ultimately the mechanism of action there. So, and before I jump into that, any thoughts, Dr. Joves, before?
No, I think that's is a good introduction as to why this is important. I will say, as we were kind of thinking about the best journal article to talk about when we think about discogenic pain, this was one that came up, partly because it was a good friend that published this, but also, obviously, I think this has been something that people have been looking at for a long time, and so seeing an article that was done, and I think fairly well in this regard, was something that I wanted to review. But one of the other things I just want to mention as some data that's been coming out that's addressing a very similar type of process in terms of targeting this type of pain is the basovertebral ablation that's been published now with 5-year data, which I think was also a very interesting article, maybe not specific, technically speaking, for discogenic pain, since it's technically targeting the modic changes and changes within their vertebral bodies. But that is another expanse of pain medicine that is developing. And I think as it grows in its utility, we're really going to see how that's going to play in over the coming years. But stay tuned. I'm sure that we'll probably cover that soon, because that 5-year data has been recently published, and I thought it was pretty interesting also.
Yeah, definitely. And so, going back to the growth factors, and really the key here, like many things in life and like many things in medicine, is that what we're seeing when we're having advanced disc degeneration and problems is this imbalance in the homeostasis of the disc. And so what we're trying to accomplish with our therapies is really to restore to some level that homeostasis and to optimize the regenerative processes. That's really the bottom line. That, obviously a lot of different pathways that are being taken to try to accomplish that, or different tools that are being utilized to accomplish that. But that's the bottom line, is trying to have a positive impact on that homeostasis of the disc, the balance between catabolism and anabolism, and trying to have a positive impact on that regenerative process as much as we can. So and they do a great job in this article in terms of going through the basic science research that's been done. And so I'm not going to get to every growth factor and its impact on the disc, but I just like I said, I wanted to highlight a couple, because we've talked about those previously in our talks about platelet-rich plasma as well. So one of the first ones is that basic science research has identified certain targets to have a positive impact on disc health, including multiple members of the TGF, or the transforming growth factor beta superfamily, which have influences on, like I said, maintaining that disc homeostasis and having positive effects on anabolic processes. Now, those TGF beta growth factors are not the only ones that have been shown to have a positive effect. Also, platelet-derived growth factor has also been shown to have a positive impact on the cell, in the sense that it helps to slow down or prevent apoptosis of the important cells in the disc, as well as to, again, stimulate some of the production of that type 2 collagen in the nucleus pulposus, as well as to help increase some of that proteoglycan content. So, recurrent themes that you're going to see over and over again is trying to get that collagen back to the natural type collagen that was beneficial for the disc, as well as restoring some of that proteoglycan and water content. In fact, a lot of the studies, when they're looking at outcome measures, will evaluate for that increased T2 signal in the center of the disc, which ultimately has been shown to correlate with disc pain, which ultimately would make sense, because improved water content theoretically would decompress that disc to some degree and decrease some of the clinical symptoms for the patient. Now, obviously, with TGF beta being on one side in terms of promoting anabolic processes, with this balance that we have, the other thought process would be trying to slow down catabolic processes. So that also has been studied, and I think, as I had mentioned earlier, when we think about this excessive catabolic processes, one of the major things driving that is an overexpression of these matrix metalloproteinases, which ultimately play a major role in or have been shown to play a major role in disc degeneration. So what's interesting is that certain cytokines activate those proteinases, and some of the major ones that have been shown to do that include tumor necrosis factor alpha and then interleukin-1. And so I thought it was a cool way to wrap our mind around it, because as we know, etanercept, which clinically we've seen that medication used in certain disease processes, obviously including rheumatologic disease processes, but etanercept is a tumor necrosis factor alpha antagonist. And so just like I said, I think it makes a good connection here that if you can, because the studies essentially show that for patients with discogenic pain, when they utilized etanercept, they had an improvement in their pain scores and function in terms of that limiting discogenic pain. And so clearly, the etanercept is having an antagonist effect on the cytokine, which then ultimately is going to decrease some of that catabolic or proteinase activity. So essentially 2 different ways you can approach it, trying to optimize that anabolic process or decrease that catabolic process. Now, in terms of the studies themselves, again, this article did a great job of reviewing the literature that's out there, and including with summary tables. But the kind of the major things they looked at was, clearly platelet-rich plasma. We brought that up before, the mechanism of how this degeneration is progressing. It makes sense that platelet-rich plasma would be something that could be effective. They also looked at prolotherapy and then the use of radiopaque jellified ethanol. And I'm going to predominantly focus on the platelet-rich plasma, but I'll mention a couple of things about the other treatments as well. Now, in terms of the platelet-rich plasma, this goes back to something we've emphasized in the past. Is there's a lot of prospective observational studies when it comes to the utilization of platelet-rich plasma for discogenic pain. And so, as we've emphasized before, and we know as a medical community, we're working towards this in terms of creating more stronger or larger powered studies that are randomized controlled trials, and not just randomized controlled trials, but have that control group that is, either conservative treatment or really trying to make it as true of a control as possible. And so, as I mentioned, there's multiple studies brought up that show some promising results in terms of improvement in pain and function with use of intradiscal PRP. But in terms of a study that actually had a control group, I wanted to highlight that one. So that was published in 2015 by Dr. Tukli Warsanu and colleagues, and it was a prospective double-blind randomized controlled trial. Essentially, obviously, it was looking at the efficacy of platelet-rich plasma versus contrast agent that was injected into the lumbar disc. It included around 50 patients. And one thing I liked about this study as well is that they confirmed to the best of their ability that the pain was truly coming from the disc through discography, which not all these PRP intradiscal studies have. So as I said, about 50 patients confirmed discogenic pain with discography. Then they looked at pain and function at multiple follow-up times up to 12 months, which also is good. I think even beyond that is going to be helpful in discogenic pain, because as was emphasized in this article, which I think was a good thing for them to do, is that, when we think about discogenic pain due to degeneration, this is a very chronic disease process. And so the longer follow-up we have, the better. Obviously, a year is good, but the longer and longer follow-up we can achieve with these studies, the more clinically relevant and applicable they're going to be. So essentially what this article, a specific study from 2015 showed was that there was significant improvement in pain and function in the PRP group versus the control group with a good p-value of less than 0.001. And the major downside of this article was that the follow-up stopped at 8 weeks, specifically for the control group. So in terms of the PRP group, it continued on for the full 12 months. But unfortunately for the control group, they stopped follow-up at 8 weeks, so you lost that comparison. So even though the benefit in terms of pain and function was maintained for the PRP group at the 12-month follow-up, and you would theoretically assume that the comparison would continue to map out about the same over that year. Obviously, we don't know definitively for sure because that wasn't followed up. And then the other major thing from this study was that they didn't do radiologic assessments. So just as a quick aside here, if you look at the outcomes in terms of MRI studies, it's interesting that there is significant differences from study to study. So, when you look at disc height, when you look at that increased T2 signal, both of those things, because some studies will show an improvement in pain and function, but really no change in the MRI, studies. In contrast, some studies will show improvement in pain and function with that correlates with an improvement in that water content, the T2 hyperintensity and/or disc height. And so, obviously, there's some inconsistencies there, and I think that's just reflective of continuing to work on the overall power of the studies and the control of the studies. But the last two things I just wanted to bring up, and like I said, we're not going to go quite as much in depth into these because I think I can speak for Dr. Joves and myself that we, although we utilize PRP clinically and for our patients, we don't necessarily have the clinical experience with these other two modalities. Well, prolotherapy we utilize clinically, but not necessarily intradiscally. So for prolotherapy, they discussed two studies, and essentially, as we've talked about potentially in other talks, so prolotherapy is the utilization of substances that either attract inflammation, stimulate inflammation, or act as an irritant. And so probably the most commonly used, largely in part because of its proven safety, which is attractive about it, is hypertonic dextrose, which essentially acts as an irritant and then stimulates the healing or inflammatory process. And so there was two studies looking at prolotherapy intradiscal treatment, but neither of those studies were randomized controlled trials. So even though they had positive results in terms of pain and function, again, going back to what we discussed, continuing to work on the power and the control of those studies. But that is a therapy that does have some studies showing positive impacts, and a mechanism, in terms of stimulating that regenerative cascade, ultimately makes sense again when we go back to the pathophysiology of discogenic disease or disc degeneration. The last one, interesting, radiopaque jellified ethanol. So an interesting concept here. Essentially what that is, it's a sterile, viscous intradiscal solution consisting of jellified ethanol, which is going to be more viscous than just pure ethanol, obviously. And its proposed application obviously is going to be for refractory discogenic pain without radicular or neurologic manifestations. And essentially it's injected into the nucleus pulposus, and the resulting osmotic gradient then pulls the water from the periphery of the disc to the central aspect of the disc, and theoretically would then, like as we've discussed, decompress that disc to some degree and potentially restore some of its height as well. But again, although there's multiple prospective studies showing some promising results, there's a relative paucity of randomized controlled trials. There was one randomized controlled trial, but the control was doing the radiopaque jellified ethanol with or without pulsed radiofrequency ablation. So again, it wasn't a conservative measure or a kind of a true control there. But interestingly, in that study, just as an aside, the group that got the pulsed radiofrequency ablation along with the jellified ethanol had superior outcomes in terms of pain and function.
Yeah. Yeah, I mean, I think this was a really interesting way of looking at it. I mean, obviously, the radiopaque jellified ethanol was not something that I had read a lot about prior to this. And so including this in the study, I think was at least interesting to expose something that's been being looked at a little bit more over time. But they did a really good job of kind of going from the basic science of things and really explaining the process at which we believe the PRP to be working, right? Which is, as you brought up, the way that it's trying to go exactly against all of that degradation cascade that happens over time for those discs. And then really take it into the clinical side of things to be able to really understand. And, we're finding more and more data. Like you said, we don't have studies that would quite meet that gold standard of what medicine considers to be the gold standard of the double-blind randomized controlled with 5,000 patients. But as we brought up before, not a lot in pain does have that kind of evidence. We have patients that either respond or don't respond to our more conservative options, and then we look for other options for those patients that don't respond. And so we end up with these studies that some of them are more observational, some of them tend to be just a treatment arm and don't have the double-blind nature to be able to develop that evidence. And hopefully we continue to evolve that over time. But at the same time, we're dealing with patients that are severely in pain and losing function. And so it does become a challenge to be saying, oh, well, you may or may not get treated, and we're going to follow you for 5 years, and we're just going to watch you, kind of degrade your function and your quality of life. And so, it's always that balance, right? And making sure that we get the right science, that we try to do things in the best way possible, but also trying to help take care of our patients in an ongoing manner.
Yeah, and I think one of the nice things, so there's two thoughts I had that came to my head. So number one, I think one of the nice things about platelet-rich plasma, PRP, is that yes, absolutely, we need larger studies with even better control and to replicate those studies. But because PRP has been studied across multiple applications and studied over an extended period of time now, we can, as clinicians, we can be confident in the safety data from a PRP standpoint. And when you're putting a needle in the disc, of course, things come to mind: discitis, osteomyelitis. But again, in part because there's been so many different treatment modalities, different biologics that have been studied. We're starting to get more and more, and then obviously you have the discography data as well, but you're starting to get more and more safety data so that because when we think about, to Dr. Joves' point, we have this patient who has a major, severe impact on their function, quality of life, and ultimately health. When we look at this therapy, sure, we want to continue to optimize the research behind it, but we also, when we look from a risk-benefit standpoint and potentially compared to other treatment options available to them, there is some, I know, at least for me, when I talk about this therapy for my patients, intradiscal PRP, I feel confident from a risk-benefit standpoint discussing that with my patients. And I guess the last thing I would bring up is that it's a good thing and a bad thing that there are so many different substances being studied to treat disc degeneration and to be injected intradiscally. It's a good thing because a lot of research is being done and it's giving us more and more data, including safety data. But it's also, so rather than being just focused on, okay, let's just study this specific type of platelet-rich plasma, leukocyte poor, leukocyte. So rather than just studying one specific thing delivered in one specific manner, there's a ton of research going on with a bunch of different modalities and different substances. So it's a good and a bad thing because, like I said, it'll be good to kind of focus on. And I think that's when if someone's kind of criticizing this therapy, I think that's one of the things they keep thinking about is where's the standardization of the therapy that we're trying to administer and study. And so obviously we'll continue to work on that.
Yeah. And I mean, I think that is a valid point, right? There isn't really a standardization of this treatment modality. But like you said, as long as we're continuing to see good safety data around these interventions, and we are seeing good safety data around these interventions, that continuing to try to help these patients is what we have to do. I mean, it just is, right? I mean, these are patients that, if you look at the large meta-analysis, there's not a lot of things that really help these patients, and so, from a procedural standpoint, even really from a surgical standpoint, yes, you can fuse those areas and you can provide stability at that one point, but that the long-term efficacy of that is, I think, in question, and not to mention the fact that we know that once you fuse and change the anatomy, now you have set the patient up for some longer-term repercussions with adjacent segment disease and the like. So, the research is growing. Ricky, Dr. Singh, thank you so much for providing this article. I think it was interesting and stimulating for me, especially. I enjoyed going through it. I think it only adds to the growing amount of knowledge that we're all trying to learn for this. And yeah, I mean, we, as I brought up earlier, in thinking about journal clubs related to discogenic pain, we'll likely circle back and kind of target another article that's recently been recent publications talking about that, targeting the basovertebral radiofrequency ablation. Dr. Karvelas, closing thoughts.
That's it. Thank you, guys.
All right, guys. Thank you for listening. It really does mean the world to us that you guys are listening and paying attention to everything that we're doing. If you enjoy what we're providing for you, the education and just maybe something to occupy your mind while you're driving to the hospital in the morning, please leave us a review, send us a message. It really does mean the world to us for you to take the 3 to 17 seconds to rate us on any of the podcasting platforms. Helps us to get heard more and to be able to share this information. So we do appreciate that, and stay tuned for those legal disclaimers.